from Croaky, and we're at the World Indigenous Cancer Conference, the inaugural one in Brisbane, and I'm talking to Linda, who is going to pronounce her last name. Everybody here calls you Linda B, and I know we shouldn't do that. Could you please tell me your name and what your role is, and your personal background?
Sure. The name is pronounced Burhansstipanov. It sounds like bird in the hand stepping off. Everyone calls me Linda B. I am not offended. The name is taken to honor my stepfather, which is our custom, to take the name of someone to honor them, and he was such a big blessing in my life. He was never offended by people shortening the name, so I am not offended. No one else should be intimidated by the name. I'm Cherokee Nation of Oklahoma. I have worked in Indian country. I'm from the United States, and I have worked with American Indian issues for about 35 years, and it's been an interesting path with many different areas. I started with women's violence back in the late 70s, and HIV/AIDS, and then an Indian elder came up to me at one of our gatherings and he says, "You need to be working in cancer." And the appropriate answer is, "Thank you, grandfather." And that's it. I switched fields.
and how long ago was that?
Oh, that was in the early 80s.
And now you're working across the fields and internationally.
Yes.
Yeah. So what you talked about today was about the Native Sisters program.
Yes.
That is really only one of many things you could have talked about, but it was very interesting in terms of patient navigation. Can you tell me the background to that, because it was interesting where it came from and then what you've developed?
Sure. The concept of patient navigation came from Dr. Harold Freeman. He worked at Harlem Hospital in New York City, and he's an oncologist, and he became very upset because he had African American patients presenting to him, first time they'd ever seen a doctor, and they had open sores, inspiration of the breast tissue because the tumor had grown so badly, and he was very upset that there had to be a better way to get people in to see a doctor earlier, and the issues were that the healthcare systems were so complicated, and people didn't know where to go and how to get there, and they didn't understand the words that were being used. So he trained his staff, local people in the area, and they became educated. And actually in his program, he's now in the Ralph Lauren Cancer Center, so they're able to really tailor it. They'll have a patient navigator that if you come in and you need help with your medication, they'll explain what methotrexate is, or adriamycin, or any of the different cancer drugs, and they'll explain, and that's their whole type of navigation, and they help you understand if you're responding well or not responding, and down to a lot of detail on how your liver metabolizes drugs if somebody's really having a lot of side effects. They're quite, and others would be dealing with access, how to get to and from the hospital to get to your treatments and so on. So I was working at the National Cancer Institute at the time. I met Dr. Freeman, and he's just a wonderful man, just a very, very gentle heart. And when I left the institute and went back to work in my community, I called and I said, we're not in a hospital. We're a community-based program. We're nonprofit. We're American Indian. What should we be doing, or how can we do this type of a model? And he says, "Oh, I don't know, but when you find out, let me know." And I had also been introduced to the program, the patient navigation program from Emihale in Hawaii, that was based out of Papa'ololokahi. And Joanne Sark from that program and her whole team were very willing to share what they had been learning. And so Harold's program started over here, and theirs started thinking about navigating on how they paddle from island to island, and that's much how it is in negotiating with the healthcare system. So that's kind of how Joanne approached it. So they kind of developed parallel. but reinforced one another. So they were very helpful in us getting started. And we started our first program in 1994. And we were funded by Robert Wood Johnson Foundation. And we didn't know what we were doing. And so we just said, well, what do you think? And the whole staff, we get together, we said, I think we need to do this. Okay. So it was very much the blind leading the blind. And then I would run into Dr. Freeman and I'd say, okay, we're doing our program. And he'd say, well, how are you doing this? And I said, well, we have to do it differently because we're out in the community, we're doing this. And then, so we do sort of like community health workers and outreach. But we bring patients in, and where many community health workers, at least at that point in time, they used to kind of stop at the threshold of the clinic and not go in. And our ladies, our Native sisters, would cross the threshold and still be with them, and then work with the other people in the hospital staff. And there's just so many different ways it helps.
And so how available are they to patients? Is it are they attached to particular patients, or are they attached to particular places?
Well, they're done differently, and a lot of that is still being worked out in the States. It's not like one size fits all. There are some people who are only based in clinical settings, and ours are not. We do from the community. We're embedded in our community, and then we come in with the patient. But like for one single patient in our program, we may have 4 navigators work with that patient because they need different things. And the navigators work with many different patients, and it could be that they have an appointment at the same time in 2 different hospitals. So maybe Audrey will go help someone over here and Denise will help someone over there. Maybe Audrey's helped this one before. Well, we have a program that helps her learn what else has been done so that she doesn't start from scratch and learning what happened with that patient. That's our patient navigation evaluation program I was referring to.
Now, one of the examples you gave of what they can do was in a hospital involving a chair. Can you just tell that story?
Yeah, and actually that's a story from Audrey. Audrey is Oneida in Turtle Mountain tribe. And she's just really good about she's so down to earth. People trust her. They know that she understands the culture. And this patient was very upset in the hospital. And Audrey, the nurses couldn't figure out why the patient was so upset. And Audrey came in and talked and found out that the patient was concerned about a chair being left in the hospital room at night, and that the spirits of people who had died in the hospital would come in and basically interfere with her healing process. And this has happened in more than one cases with something similar to the chair. But and so the solution was to put the chair in the hallway. Well, the first night the nurses were putting the chair back in because it was obstructing the hallway a little bit, and they didn't understand. And then Audrey explained that she was upset about the spirits coming in, and that they were going to affect spiritually. She would not be able to heal as well.
And is that the role of the navigators? That's just one part. Is the spiritual beliefs? What is the need for them, and what do they do?
Oh, they do so many things. They're absolutely marvelous. But they basically, our navigators work through the full continuum of the cancer care. So our model is quite different than what it originally started with. So if somebody is having difficulty getting into treatment, they help them find a way or even into a screening service. They help them get signed up for screening, make certain that they follow up, and if they don't, they find out why they didn't. Oh, my daughter had the flu, or I got called into work, I had to work, and okay, well, this is important for you to have your appointment. And when the Native sisters get involved with them, compliance with screening, or if they've had an abnormal test and they're afraid to find out the results, so they don't want to go in and find out that it could be a positive biopsy, but most of the time it's not. Most of the time they're healthy. Then the sister makes them go that extra step to find out what it is. If they're having symptoms and they don't know how to explain the symptoms to them, or if they need to talk in their native tongue. Some of our sisters speak more than one native language, and so Lisa speaks Seminole. So if somebody comes in, and when you're frightened, you go back to your first tongue. So they want to talk in their first language, and then she can explain to the doctor what's being said instead of trying to translate from English into your first tongue what's being said, figure out what's bothering you, figure out what you want to say, have to translate it back to English, and then say it to the doctor. In that long pause, the doctor usually is not patient enough for it. So they talk on top of the words. The native sisters they make them slow down. They make the providers take more time to speak with them. And I think one of the other examples I gave is when we were first starting it, because I play the role before I have our staff do things, so I can experience also what could go amok. And I did things very wrong the first time. I had the lady with me, and I turned around. I knew she wasn't understanding what the doctor was saying. It was too much medical jargon. And stupidly, I said, "Do you understand what the doctor just told you?" And that's when she says, "Oh, yes, I'm not going to die this winter." And the provider was shocked, but I was equally shocked because I realized I had asked a question that all she had to do, she could have said yes or no, but she was very polite and gave me a statement, and I needed to ask the question differently. And so I stepped and I said, "Okay, when you go home today and you talk to your sister, how will you tell your sister what the doctor just told you?" And then she told a story quite different than what the doctor was saying on it, and it helped the doctor understand. And by the third time we worked with that provider, we meaning the native sisters, not just me, it's our team, the doctor was communicating so much more appropriately with the patient. A lot of it is they help the providers, any of the hospital staff, slow down the rate of speech when they're talking to a patient, especially when someone's scared and they're, again, translating in their mind to their first tongue and going through that whole process. They also are so used to talking on top of one another's words because that's the European pattern of speech. You listen to it any place around here, and someone is not done with the conversation and someone talks on top of them. I don't know of any native culture that does that. It's disrespectful. You don't do that. So it's basically the native sisters then say, "Excuse me, doctor, whatever, I need for you to wait a minute before you speak." "Well, I'm in a hurry." I said, "She is too. She has to get home to her family." And
how many are there? I mean, is it that any Native American cancer patient in your area is able to tap into this?
In our area, we're well known in our area, and so we're not hired by clinics because our population is so small. Our goal is that clinics, when they realize that they have a Native patient, that they reach out to our program and they have one of our navigators come in and help, and that they pay our navigators. Our navigators need to pay their bills like everybody else. They cannot be volunteers for this type of work, and they take a lot of training. I mentioned in there when we first started our project, we had like 80 hours of training, and then it's a minimum of 225 hours now for if someone's doing comprehensive, and then there's in-service along the way, and then the navigators say what they need also. So if I'm supervising or if Lisa's supervising, we'll say, "Wait, we need to go back and do that clinical trials module again." They're not quite understanding some of the delicacies that are in there. Or if we have a module that's on how to protect your spirit, so that if I'm working with you as a patient and you are very, very upset, it's very easy for me emotionally and spiritually to get wrapped up in that I have to still protect my spiritual being here so that I can help you in the best way. And Lisa does a beautiful job of doing this training of how you protect your heart and your spirit while you're helping somebody else, so that you don't go home and you're not upset and angry with your family, and that you don't carry the trauma into your next relationship or your next conversation. And that's important. And culturally, we do it different ways.
Sorry, but with that, how do you have to evaluate and measure success? How do you
Yes.
how do you regard success?
We have We actually have quite a few different measures. We're very well known. Native American Cancer Research Corporation is very well known for being very high-level evaluation modules. So we observe, as part of service training and process evaluation. What our big measures are is that we look at the shortening of time from the time somebody is recommended to screening to when they schedule an appointment. If they cancel the appointment, how long it takes, how many times before they actually complete it. We track all of that interval. And we find when the Native sisters are involved, that interval becomes much shorter. It's much more efficient. It saves money for everyone. If they are referred for follow-up care, how long it takes to get them, and are they getting the correct follow-up care? Because sometimes we get referred to in the United States, few people understand Indian Health Service, and so they will automatically just say go to Indian Health Service. Well, like in our survivorship network, only 12% of our survivors use Indian Health Service because there are no oncologists. Everything is referred. It goes through a very complicated, but we won't get into on this, but it goes through contracted health service. And the Native sisters understand how that works, and it's like, wait, we have to go a different way around this. We cannot be on the waiting list. So those types of things are important in getting people into the system quickly. We do quality of life measures to see how well people are doing. They give us their self-evaluation as well as we have assessments to give us an idea. Occasionally we'll do an external type of a test depending on what type of a program they're in with us, because we do patient navigation for tobacco use, for physical activity, so for prevention, for screening programs, diagnosis, treatment, quality of life, palliative care, comfort care, end of life. So we do this whole circle of this, and the navigators are involved in all of that. We have an online evaluation program that if I am visiting with you, when I'm done with the visit, I track on little sheets where it was in the continuum, if it's prevention, screening, early detection, where it is in that whole continuum. I have little check boxes that I mark that I help you fill out paperwork. I help you schedule an appointment, how many minutes I spend on it. I can get a report. You have a code number in our program, and I can get a report that tells me how many minutes that maybe Denise, maybe Audrey, maybe Lisa, all three of them worked with the same patient. Maybe they had 12 visits. Our evaluation program will summarize what they did on every visit, how many minutes overall they spent, and so we can quantify the tasks, and then we have them evaluate the Native sister, how well the Native sister met their needs. So we do quantitative, qualitative. In the end run is that we like to see people getting earlier and earlier diagnoses. When we first started our survivorship program, we primarily had stage 3 and 4 people coming into our program, and in the last 8 years, the majority of people who come into our program are stage 1 and 2, 0, 1, and 2. It's due to the navigators. They also do community education, by the way. They do workshops in the community to educate people about the full continuum. So we basically have about 40 hours worth of workshops that are community, and communities will say, we want a workshop on brain cancer, or we want to have a workshop on how to support the caregivers so that they're not going off the deep end being a sole caregiver. And the navigators are the one, or the Native sisters are the one who do this, and that increases their visibility in the community. So there's not a lot of us. We have some navigators that work with our program that are down in the southeast. Others are in Oklahoma. We have some in South Dakota. We have some in North Dakota. We partner with a program in South Dakota that they call their navigators community research representatives, and that's the Walking Forward program, and they're quite good. So we have pockets, but it's not like you can just call up. So we run a hotline for those who don't have any services anywhere. Our navigators are the ones who help them. They answer their questions, and they kind of walk them through the whole process. And they help them figure out questions they need to ask the provider. They work with the family members to help the family members cope and understand what's going on, that cancer does not have to be a death sentence, that more and more of our people are living, and they're living well, after the cancer diagnosis.
So how many navigators, how many Native Sisters are there?
In our program, based in Denver, we have 3.
And they do all that?
Oh yeah, but remember, we're a small population, so they do so they do a few minutes of here and there of what they do. And in the southeast we have a couple, and in Oklahoma we have a couple, and in Arizona we did have 3, it's a crazy thing, but they passed. They walked on for not related to cancer, but they passed away. So we've lost them. And the Northwest has a separate program, so they're not all run through us by any means. These are other programs that people have seen the value. Great Plains Tribal Chairman's Health Board has a patient navigation program that is very successful. So there's there's just little pockets, but there'll be 2 or 3 people in each of the different settings.
I imagined hundreds.
Oh no, not yet.
Not yet.
Not yet.
Jumping to the bigger picture, because everyone's heading to the meeting you're supposed to head to.
Yeah.
What are you taking out of this inaugural International Indigenous Conference?
You learn a lot at any cancer conference that you go to, but when you come to an Indigenous gathering, there's such a spiritual strength, there's such a warmth and balance in everything that's done, is that you get the passion of how much our people care for the well-being of our people, and how we realize that we can be healthy again like our ancestors were, that we can do things in a good way. And you just meet so many beautiful people. The networking is one of the best things. I mentioned to you before we start doing this that at the previous Indigenous gathering, I spent if I wasn't doing a session, I was in the yarning circle.
And what is it about the yarning circle for you?
I think the stories, even though people, scientists like to say, oh, well, it's anecdotal data, it's not scientific. There is great power in stories. It's our traditional way of teaching our young how to do things. All of our native cultures have stories about why you do things a certain way. And it's not just natives, it's even white cultures, other cultures. They have storytelling and so on for this reason. Our storytelling is a bit more elaborate than many other cultures do, but also in our stories, we touch on what we call the medicine wheel: mind, body, emotion, and spirit. And in that, you get the whole perspective of what it is, and you have a chance to, many of if you listen to traditional American Indian stories, they kind of go along and then they just kind of end. And you're kind of like, and you have to sit through and think through what the ending should be and what the message is. And so we don't take away the ending, from it, and that's an important thing, and that's what we get from many of the stories.
So what will be your take-home thing? Can you tell yet?
Oh, I think friendship. I think really, every time I come here, I am astounded at how similar our cultures are. When I came here in 2008, we were out in Alice Springs, and we were meeting with the palliative care or the comfort care programs, and the local team there brought up their Aboriginal materials, and I brought some of our American Indian materials. You basically, if you swapped out the photos, they were the same. And some words, like you talk about mob, we talk about clan, or we talk about tribe or band, but it's much the same concept. The messages were the same, in all of them.
And that was one of the things that came up too, when you said around mistrust of the health system is also a very big thing for you. Yeah. Would you say that that's one of the biggest issues in terms of particularly around screening?
Mistrust is there, and I think it was much worse in 20 years ago than it is now. I think that our communities have become more proactive in many ways. We don't have, you have many things better than what we do. You have easier access to getting into cancer care than we do, even though with our new healthcare system, which people call Obamacare in the States, it has definitely improved for Indian people and for any cancer patient. Actually, it's improved. You don't go bankrupt anymore with the cancer treatment. But lack of health insurance or insufficient health insurance is still a major issue. Access, including transportation, it's something like 15% of our cancer patients in our survivorship network travel more than 400 miles one way to get help, which is very similar to what you have here in Australia in many parts. Many of them travel 2 and 3 days, same as you do, to get help. Well, during that time, who takes care of your family? And we have people that they're taken away by the plane, and children will say, "I don't want to get on the plane because they took mom and she never came back." And that type of a concept is very difficult. But we can't get care in our local communities for this. Well, some places like the Alaska Native Medical Center has a live-in facility where the family members can live right next door to where the patient is, and keeps the family intact a bit more.
But that's still quite unusual, yeah?
Oh yeah, that is not the norm. But in Alaska and in some of our other communities, we rely on subsistence hunting. Well, if you're not well enough to do subsistence hunting, how do you survive the winter? And luckily, the neighbors have said, "Oh, I'm hunting extra, and I'm gonna clean the well more so that there's a portion for, my neighbor, and she's down in Anchorage getting treatment." That's but the community pulling together is very important. There are so many issues that are culture that are embedded that people don't even realize when we first look at it. A woman coming in, and when you're frightened, again, you go back to your first language, which isn't English for many people. And a woman was talking with the nurse, and she came in the emergency room because she didn't have health insurance, and the nurse is asking her questions very, very rapidly, and she's still trying to think of what the question is asking her before she was even figuring out how to answer it. And the nurse just gets all frustrated. She slammed the little curtain closed on her, and she's talking right on the other side of the curtain. It's not like this is a wall, just a little curtain. And she is saying, "She must be drunk or retarded. You know how those Indians are." The woman heard that. She understood that quite clearly. And she stepped out. She says, "I have a master's degree, and I don't drink." And she just left, but she didn't get care. So once again, she delayed access to care. And see, so sometimes when we look at the different layers of barriers, there's things that are kind of at the heart of the issue, which very often are cultural things, or it's subtle ways of racism that occur that a well-meaning healthcare person may not even realize, it is or is not appropriate. They may be very warm and caring and reach out and touch, not realizing that for your tribe or for your clan, that you're not supposed to be touched, and there's certain times of the month or the year when you're not supposed to touch, or just saying, "Oh, your hair is so lovely." Well, there are times that you are not supposed to touch hair. That hair has a special power, and it's different by different tribes, and so there's subtle things like that. Then you get into other types of barriers that are more common, that are just like transportation, not having insurance, not having copay, things like that anybody who is poor is going to deal with it. So they're poverty-related types of issues. And then you have socio-cultural, where you're not comfortable going into a clinic. I think an example I gave in one of the talks here was that one of our clinics uses owls as a form of direction for how you find the radiation oncology area, and an owl is a symbol of death for many tribes, certainly not all, but for many tribes. So why are they going to go down and follow this symbol of death?
What did you do about that?
The Native sisters talked with the nurses, who were quite wonderful, and said, I'm going to take her outside, snowing, very cold. Took this little woman outside the whole hospital, going around it, and knocked on the door outside the room so that she wouldn't have to be exposed to seeing the owls while she went into radiation.
So many layers that have just been buried over this time.
Oh, it's so many, so many different things, but they're to me, the Native sisters can address almost every one of the issues that we have, but we have ways that they are paid a competitive wage.
And they're not employed by you?
Yes.
Oh, they are? Okay.
Yes. They're employed by us, but we're funded by soft money, by grant money. And right now we're very low in money, so our Native sisters are paid for this type of cancer because we've got a small grant on that, and these others, they're donating their time. Because they want people to have a better experience than what they had.
I'll stop you there, Linda, but thank you so very much.
Sure, thank you.
The similarities are incredible. The differences are quite joyous to discover in many ways, but also terrible ones as well.
Yeah.
Thank you very much.
Oh, thank you.